Need to make sure. Pause. Hello, everyone, and welcome to From the Experts. My name is Sumaira. I am myself a double seronegative patient, and I'm also the founder and executive director of the Sumaira Foundation. Today, we are here with Dr. Eoin Flanagan from Mayo, who will introduce himself in a second, to discuss double seronegative NMOSD, a hot topic for everyone who is here and watching. But before I get started, just a few housekeeping items. First, I'd like to say that this webinar is being recorded and will be available for replay on our Facebook video library, our YouTube channel, and on our website. So you can always go back and reference all the information and things that we talk about today. We are going to have a dedicated Q&A section towards the end of the webinar. So the last 30 minutes of the webinar, you will have the opportunity to ask Dr. Flanagan questions live in real time, and he will get to as many of them as possible. So don't be shy and populate your questions either in the chat function or the Q&A function. And lastly, I'd like to thank our sponsor, Horizon Therapeutics, for making this session possible. So without further ado, Dr. Flanagan, thanks for being here.
Yeah, it's a pleasure to be here, yeah. So I'm a neurologist from Ireland originally, but I work at the moment at the Mayo Clinic in Rochester, Minnesota. I work in neurology and the neuroimmunology lab, where we do some of the testing for some of the antibodies that we'll talk about today.
Fantastic. And if you're wondering how we're together in person, we're actually doing this webinar live from Denver, Colorado, where we're both attending, and I think we're both faculty here at CMSC 2023. So that's the Consortium of Multiple Sclerosis Centers, their annual meeting. And I'm sure you will all appreciate that there's a lot going on about NMOSD and MOGAD here at this MS conference. So let's dive in.
Sure.
Tell our audience, what does it mean to be double seronegative?
So when we talk about double seronegative, we're talking about two antibody tests that we can do that are markers of NMOSD. So one of the antibodies is called the aquaporin 4 antibody, and the other antibody is called myelin oligodendrocyte glycoprotein antibody, or MOG antibody. And when patients are negative for both of those antibodies, but they still have the syndrome that's similar, that we term neuromyelitis optica spectrum disorder, neuromyelitis meaning involvement of the neurologic system, myelitis meaning inflammation of the spinal cord, and optica meaning inflammation of the optic nerve. So if you have that constellation of features and you're negative for those antibodies, then you can fall into this category of seronegative, double seronegative NMOSD.
And if you had to estimate, I don't know if there's actual data on this, how many people out of our entire spectrum are double seronegative percentage?
Yeah, I think maybe about 20% are negative for the aquaporin 4 and fulfill that NMOSD criteria. But there's probably many more patients out there who fall along that spectrum who don't have a defined diagnosis. And I think there are great areas for research where we can learn more about, are there antibodies that are associated with those conditions, and how can we learn more so we can develop treatments for those, like we have for aquaporin 4 antibody positive NMOSD.
20% is significant.
Yeah, it's a big number.
Yeah. Okay. And so I'm going to rewind a little bit. In 2017, the MOGAD antibody was discovered, right?
2007, Kevin O'Connor first discovered that the MOG antibody was a marker of a pediatric demyelinating type disease. And then later on, the antibody became available around 2017 at the Mayo Clinic, where we developed it in the USA, and it had been available in Europe just a little bit before that too.
So it's only been about 6 years since that antibody has been tested for, right?
Yeah, exactly. Yeah.
So my question to you is, all the patients, all these double seronegative patients before 2017 who tested negative for aquaporin 4, what are the chances that they may have had MOGAD, but the test wasn't there?
Yeah, absolutely. Yeah. So I think probably about 30% of those patients would end up having MOGAD. So I think the first thing is that if you're a seronegative NMOSD and you were diagnosed before 2017, you should go and get your MOG antibody tested, because that would be important, and it might be positive. There would be a 1 in 3 chance probably of that being positive. So I think that's important.
Okay. And for our patients who are watching, who are double seronegative, how often should they be getting tested for both antibodies?
Yeah, well, I think there's a couple of ways to think about that. One is testing in the blood. So we can test in the blood. So if you have the seronegative NMOSD syndrome, then you should be tested for the aquaporin 4 and the MOG antibody at the time you first see your physician. And if it's negative and there's a high suspicion, we might consider retesting at 6 months or 12 months, because sometimes we can miss it initially, and then later on, in about 1% of people, it can become positive. And if it continues to be negative for, a year or two, then at that point you might be wanting to look at maybe, sending some antibodies to a research laboratory, like at Mayo Clinic. We do some research and we try and figure out antibody markers for diseases that don't have a definition right now. And just many other laboratories, Oxford in the UK, Barcelona in Spain, and other laboratories that will do that. So there might be interest in looking for other antibodies beyond the aquaporin 4 and MOG to see if we can kind of define better what those diseases are. And maybe there's a third and a fourth antibody. So
we're going to get to that.
Yeah.
We're going to get to that. But while we're on the topic of testing, as you know, Dr. Flanagan, many patients oftentimes have to advocate for themselves, right? Especially when they're not fortunate to go to doctors like you at Mayo and what have you. So all this to say that I want to make sure that our patients know and feel comfortable asking their doctors proactively, if the doctors aren't recommending themselves, that they should be getting tested again. So can you speak a little bit to our patient community about what the different tests are? I know there are different mechanisms, how to ask your doctor, which test are you using, that kind of thing.
So I think for the aquaporin 4 antibody first, it's recommended that patients get a cell-based assay, which is a particular type of assay that seems to work best for diagnosing NMOSD. So some of the older generation antibodies, when they were first discovered, wouldn't pick up as many cases. So now we pick up 20 or 30% more with the cell-based assay. So in the diagnostic criteria for NMOSD, it's recommended that you do a cell-based assay. So I think you want to ask your doctor if you can send a blood sample for a cell-based assay for aquaporin 4. The second question might be, for the MOG antibody, would be also a cell-based assay is recommended. There's a couple of types of cell-based assays, so it gets a bit complicated, right? It's hard for you guys to keep up with all of these terminologies, but there's basically a cell-based assay where you use live cells, so the cells are alive, and in that situation, you probably better recapitulate real life. So the live cell-based assay seems to be a little bit better than the fixed cell-based assay, which is kind of a killed, the cells are not alive. So that's a difference, and the live cell-based assay seems to have a little bit better, particularly for the MOG antibody, a little bit better at picking up the diagnosis. The second question you might ask is, well, what about spinal fluid? So sometimes with the aquaporin 4 antibody, we don't tend to pick up many more cases. Most of them are present in the blood, and we can sometimes pick it up also in the spinal fluid, but it's very rare that we would pick it up in the spinal fluid and it will not be in the blood. On the contrary, that would be kind of like less than 1% or even less than 0.5%. On the contrary, with MOG antibody associated disease, or MOGAD, we can pick up maybe 10% of cases with the antibody in the spinal fluid. So if you're negative in the blood, you might want to consider sending an antibody in the spinal fluid to look for that and see if that's positive. So I think there's some aspects there. So testing in the blood and the spinal fluid, if there's a high suspicion, testing both for both antibodies is perfectly reasonable.
Okay. I've been an advocate for about 9 years and have had the pleasure of speaking and meeting with so many patients across the world. And one thing that I noticed, just from my very limited vantage point, I'm not a science person, but one thing I noticed is that so many of the seronegative, double seronegative patients I come into contact with are oftentimes far more debilitated than the MOGAD patients and the aquaporin 4 positive patients. They're wheelchair bound and blind. Do you see this too? Is that an observation for you?
Well, we see that the treatments don't work as well. Yeah. So I think we struggle a bit with having a good treatment, and that might mean that they have more attacks. The other thing to mention with the double seronegative NMOSD is important that is kind of a broad range. There can be a broad range of things that can cause that. So you need to look wide as a physician. We need to make it what we call a diagnosis of exclusion, which means we need to test for other things like sarcoidosis or tumors or other things, make sure that we're on the right track with the seronegative NMOSD, because there are other things that can look like it, genetic conditions and different things. So we usually want to do a broad range of investigations. And then if we're left with the seronegative NMOSD, I agree, it's kind of more challenging to treat those patients. And then sometimes they get more disability because we don't have proven treatments like we do for the aquaporin 4 antibody positive NMOSD. So that makes it harder. Yeah.
For me, it's kind of related, but another topic, but so often we hear about NMOSD and MOGAD patients being misdiagnosed with MS. But alternatively, I have been asked a lot by double seronegative patients, what if I actually have MS? So the reverse misdiagnosis. So how would you exclude MS from double seronegative patients?
I do a lot of studies on MRI, and we look at the different patterns of MRI, and multiple sclerosis means multiple scars. And oftentimes the pattern of those scars that we can see on the MRI in the brain and the spinal cord can help us. And in the spinal fluid, we look for something called oligoclonal bands, which are a marker of inflammation. So if we put all those together, a lot of times we can figure out if it's MS. So I think you want to, if you are diagnosed with double seronegative NMOSD or concerned about MS, you should probably see a specialist rather than a general neurologist. An MS specialist should be able to tease out those cases that are MS, because of course with MS, we don't have a single blood test like we do for the ACOPORN4 positive NMOSD and the MOGAD. We have blood tests for those, but for MS we don't. So, but a lot of times we can recognize MS pretty well. So we sometimes look at how long the lesion is in the spinal cord and different aspects of how it affects the brain and the spinal cord.
It's not related to double seronegative, but that's always a question that I have in my mind, because there isn't an antibody for MS. So why don't we test all MS patients for NMO, ACOPORN4 or MOGAD?
Well, the problem is that the testing is not perfect.
It's hard to hear, sorry.
Okay. So the challenge is that these tests that we have are not absolutely perfect. So sometimes we can get what we call false positive results, particularly with the MOG antibody. So because MS is so much more common, it's probably 20 or 30 times more common than NMOSD or MOGAD, then if we test all of those patients, we can run into trouble where the antibody comes back positive, but it's a false positive results. So we generally select out which patients that we want to test. And we can generally, as an MS specialist, recognize MS pretty well. But in the early stages, sometimes we'll test more often because sometimes the findings are not clear when there's not a lot of involvement of the brain or spinal cord. But later on, a lot of times we can figure out if it's MS or not.
So I'm going to speak a little bit to my own personal experience, because it's been 9 years of testing negative for ACOPORN4 and the MOGAD antibody. And with that comes this frustration, because you're like, if it's not these two, then what is it? And, there's oftentimes a little bit of an identity crisis too. And you wonder, okay, if things aren't showing up in terms of antibodies, is this real? Do I have something? Should I be going through these treatments and getting poked and prodded left and right? So as a physician, when you have patients who say things like this, what's your reaction to that? Like, all patients should be treated, right?
Yeah, so I think, we have made great strides, but we're not all the way there yet. So we've discovered the ACOPORN4 antibody, which has been really helpful. And now we've got, multiple proven treatments for that disease. We've discovered the MOG antibody and the trials are underway. So I think with the seronegative NMOSD, we're going to be making more discoveries over time, and we will be able to kind of give it a better label. But sometimes when we don't know the exact disease or what the antibody is targeting or what exactly is happening, we have to use kind of a syndromic term, which means your seronegative NMOSD, which is kind of hard for patients because it's kind of like a negative terminology, like it's but some negative connotation to that potentially. So I think, though, we have to remember that these patients have a true disease and they need to be treated just as much as the other patients. And we kind of base our treatments on what has worked in things like ACOPORN4 positive NMOSD, in MOGAD, and in MS. And we can kind of figure out a treatment plan depending on patient, and sometimes we have to try different things in that situation because it's a bit more complex.
So you're treating the symptoms and not the diagnosis?
Well, we're treating the disease too. So we use both symptomatic treatments, which is to help patients' symptoms. If they've got stiffness in their legs, they need help with passing urine or passing stool. But we also use immunosuppressant medications to target the disease, because we presume that given what we know about MOG and what we know about ACOPORN4 positive NMOSD, that it's likely immune mediated. So we target the immune system. But we just don't know, because with the seronegative NMOSD, there could be 2 or 3 antibodies in there, and maybe one will respond better to one treatment or the next. So we sometimes have to do different treatments, trial and error, and see how patients respond.
In your experience, do the double seronegative patients, are they usually having only visual problems, only systemic body issues, or both?
I think they get both. I think they can get spinal cord involvement and optic nerve involvement. So we see that they can have vision trouble, they can have bowel and bladder trouble, and difficulties with fatigue and pain and things like that we have to try and manage with our. We have many medications that can help with all those things, so we have to try and kind of take a multidisciplinary approach, involve our physical medicine rehab doctors, involve our neuro-ophthalmologists, and involve sometimes our pain team to help with all of those aspects. So I think it's a kind of a team approach, and we'll have nurse practitioners, advanced practice providers who will help us try and manage these patients, because sometimes there's many different aspects to the condition that need to be treated. And if we just treat one aspect and focus on the immunotherapy, we can be forgetting about many other symptoms that need to be managed.
Totally, that's a great answer. So that was the perfect segue into treatment. So double seronegative patients, because they don't test positive for the antibodies, at least in this country, oftentimes run into many challenges getting access to therapy. So I would love to talk to you about, what are some of the go-to therapies for double seronegative NMOSD, and what's happening in the background that patients don't really know about to address these access to therapies challenges?
Yeah, I think it's hard, because the FDA requires, a randomized trial showing that a medication works. So if we don't have that in the seronegative component, we only have it in the seropositive, they only approve the medications for the seropositive. But in saying that, a lot of times we can argue with the insurance companies and say, well, this patient is having difficulties, they're having lots of attacks, and we need to use something. Just because the patient's unfortunate that we haven't yet discovered the antibody, it doesn't mean we should leave those patients without treatment. So a lot of times we'll try wide range of treatments. We sometimes use IVIG, which is kind of antibodies population to try and neutralize any bad antibodies. We sometimes use steroids acutely, and then we can use other medications like rituximab that target the antibody producing cells, the B cells, and then there's other treatments that can target IL-6 or interleukin-6, which is kind of like the fuel for the B cells to make those antibodies. So you can try and target it in many different ways to see if you can get a benefit in those patients. And I think we can make the argument to the insurance companies that this is important. But sometimes we're fighting an uphill battle and it can be hard. We have to kind of decide on a treatment that maybe we didn't want. But there are sometimes more affordable options that we can use that insurance companies are often okay with. And sometimes when it gets too expensive, then the insurance companies get more problematic.
Totally. So when I look at double seronegative patients and what's actually going on, I think of three possible outcomes. Either at some point they'll test positive for aquaporin 4, at some point they'll test positive for MOGAD, or there's an antibody that has yet to be discovered. So we're going to pin that third one. But with these two first options, are there ever any telltale signs when you're trying all these other therapies that actually this patient's responding better to this one, so maybe they actually have MOGAD, or maybe they actually have NMO?
Yeah, I suppose, if you use like the medications like eculizumab, satralizumab, or nivolizumab, and they responded well, we know they work really well in NMOSD. It's a bit harder with MOG because we don't really know what works in MOG yet. So I think it's a little bit hard there, but I think there are the situations where the patient is responding, you might want to go back and retest their antibody, retest their blood, and you might want to understand the fluid for those antibodies again. So sometimes that repeat testing is important as we go forward. If it's involved, we test them for many years, and then eventually, the testing is, there's a cutoff, and we have a cutoff. People are just below that threshold, and then they eventually hit above the threshold. So I think we're lucky with the aquaporin 4. The test is very clean. With the MOG antibodies, a little bit more sticky.
Right.
So we get into it there. Yeah.
Right. Okay. So back to the antibody conversation. So I'm sorry. I think people are having trouble hearing us. Oh, sorry. The sound is off. Can you hear us? Hello. Okay, they can hear us. We just might have to speak a little bit louder. Sorry. Dr. Oh, it's like a bad cell call. Sorry about that, guys. Okay, we're going to try our best to speak louder. Okay, so we need to, where is my, it's full. Sorry, guys, hold on one second. Let me see. Microphone, it's on. Okay, we're going to do our best to speak louder. Antibodies.
Yes.
Okay. What's happening in the research world for double seronegative patients to potentially find another antibody?
Well, I think we, Mayo Clinic and many expert centers around the country and around the world are trying to enroll those patients in research and trying to look and see, can we analyze their blood? Sometimes we can do that in many different ways in the laboratory, where we can look at the profile of the spinal fluid. And even in that situation, if we don't know what it is, sometimes we can look at the profile of the immune signature within the spinal fluid or the blood. And that can tell us, well, this marker is up high. Let's try a treatment targeting that marker, for example. So we can sometimes use that both to discover what the target is, but also to what their immune signature is. Maybe we can use the treatment that would target that immune signature.
Okay. Okay, I had another question and then I totally forgot. Sorry. It'll come back to me.
But I think the antibody. What I will say is that you can. If you think back to before 1999, we didn't even know. We thought that NMOSD was a part of MS, and then back in 2004, the antibody was first discovered. And then we refined the techniques and we were able to identify even more patients. So I think we can learn a lot from how we discovered the aquaporin 4, how we've discovered the MOG and are bringing forward treatments and really use all of those approaches. And things are getting better now with artificial intelligence and lots of other things, these techniques that we can really try and hone in on those patients and find out what antibody is causing problem. And then maybe that gives them a better identity down the line, and then we can develop a treatment better for those patients.
Great. I remember my question. It came back. Okay. Clinical trials. So there were a number for the 3 FDA approved NMOSD ones, and then there are a couple for MOGAD. Are there ever any double seronegative patients enrolled in those trials?
There were. So for the clinical trials that went ahead, the inebilizumab, the eculizumab just included aquaporin 4 positive, but the inebilizumab and satralizumab trials had patients who were negative for aquaporin 4. Some of those were positive for MOG, but some of them were negative for MOG. And they didn't seem to respond as well to the treatment, but it was only a small number of patients. So it's a little bit difficult to know. So I think we probably need to, get our heads together and try and find a trial for double seronegative NMOSD and see if we can find a treatment that could help those patients. And, that's the goal is just to try and help the patients as best as we can.
Sorry, guys. We're going to try to fix the sound because we want to make sure you're hearing everything we're talking about. So, Jill, you're there 3 times.
Yes.
Yeah. Mute my mic. So use that mic, but look at this. Okay, guys, we're back in business. How is the sound? Can everybody hear us? Can you put it in the chat? Can you hear us? When the doctor talks soft.
Oh, is it me? Sorry.
No, I'm the loud one and he's not. That makes sense. But that's good. The thing will be okay. Okay, great. Okay, sorry about that, everyone. We are back in business. I think so, yeah. The feedback isn't good. Okay, so what were we talking about?
We were talking about the antibodies discovered, the treatment trials.
The treatment trials, yes. Okay. So there were double seronegative patients in the treatment trials. And how did they do?
It didn't seem like there was as good a response as the aquaporin 4 antibody positive patients. So, but it's small numbers and it's hard to see a signal. So we probably need its own trial with larger numbers of patients to figure out what if we can get a treatment for those patients.
There is an echo.
Is your mic still on?
No.
We do have a mute over here.
Oh, okay, guys. How about now? Can you hear us now? The doctor is now being picked up as Jillian, and we can't see him when he talks. Oh, bummer.
Well, you will now. You will now.
Okay.
So I would just use this computer.
So look there.
Yeah, just look there.
Okay.
Sorry for the
Let's get my
technical
good
issues.
angle. Let's get my good angle.
It's okay.
Okay. So everyone can hear us now. Okay, back of business. Sorry about that. I'm ashamed. As a millennial, I should know how to do all of this, and I don't. Okay, so it wasn't as good in the clinical trials as you had hoped.
Yes, yeah,
Okay.
with the pity. So I think we need to look at studying those patients in particular
Okay.
and getting larger numbers, and then we'll be able to figure out if we can get a treatment for them. Yeah.
So are there any ongoing studies that double seronegative patients can enroll in? It doesn't have to be clinical trial, but is anyone conducting this type of research?
I think at the centers like Mayo Clinic, we're interested in kind of enrolling them into our repository.
Okay.
And many other centers are doing this where they'll enroll them and try and look at the immune markers and try and understand better about those diseases so that eventually we can find a treatment. So sometimes, we need to do that first step of finding out what immune markers are up in double seronegative NMOSD and then decide on the treatment that will work best. Because if we just throw any treatment at it, it might not work. So if we can find a way to target the treatment, that might work better.
So how do patients find out about these studies? How do they get involved? Do they just go to the
website? I suppose if they go to your website, they can probably find out some information. And the Guthrie Jackson Foundation website is another website that's good for NMOSD. At Mayo Clinic, we have a website too. If they want to come for a visit with us, they can. And there's many big centers around the country that are interested in NMOSD. So
fabulous. Okay, we're going to dive into some of your questions. So let's get to the first one. Hi, regarding the aquaporin 4 and MOG antibodies, I'm double negative, and during my first and so far only, that's good, attack, Christmas 2019, my neurologist tested me for aquaporin 4 and MOG several times, even during steroid pulses, plasmapheresis, and IVIG. All three didn't help. Cyclophosphamide helped, though. Is it worth testing me again for AQP4 and MOG 3.5 years later? I'm on rituximab. They also then tested me for neurosarcoidosis, neuroborrelia, tropharema. Whoa, these are things I don't know how to say. All negative, and MS also excluded.
Yeah, I think it's reasonable. I suppose you could consider in those situations whether it was just tested in the blood or would it be worth testing again in the spinal fluid. So I do think it might be worth testing. Also, the antibody methodologies have improved over time. So our antibodies are getting better and better. So sometimes if you send a later sample, if you sent one to Mayo Clinic 10 years ago compared to now, we have a much better test. So I think it can always be worthwhile sending those antibodies. And then you could also send a discovery panel looking for other antibodies potentially. There's many laboratories around the country, including at Mayo, that test for a broader range of antibodies, because sometimes there's another antibody. There's one called CRIM5 or other antibodies that can associate with similar syndromes.
Okay. How to distinguish between seronegative NMOSD and neurosarcoidosis isolated to CNS negative ACE test?
So neurosarcoidia can be a difficult one to diagnose. Sometimes the MRI can be helpful. In the spinal cord, it has something that we call a dorsal subpial pattern. And then we've also described a trident-like appearance where it looks like this three-pronged appearance. So sometimes on the MRI, you can get a clue. Otherwise, a test that can be useful there is called a PET scan. Sometimes we can do a PET scan of the body and it will light up brightly within the lungs, within what we call the hilar lymph nodes. And then you can do a biopsy and sometimes you can confirm sarcoid. Sometimes it's hard to see with the chest x-ray or CT alone. So sometimes you need to do a PET scan and that can be useful to help pick up sarcoid.
Okay. If we are double negative, should we make an effort to get to a higher level specialist such as Dr. Michael Levy rather than solely using local neurologists, in my case, in Maine?
Yeah, absolutely. That's a great point. I do think that if you're double seronegative NMOSD, that does require a level of expertise that might be beyond a general neurologist. Now, we often partner with those general neurologists. I wouldn't blame them or be upset with them, but it's more that they can gain from that extra expertise. And Dr. Levy is someone who has excellent expertise in double seronegative NMOSD. And there's many centers that you'll find around the country. And if you go to the different websites, you'll be able to find lists of doctors who are interested in these conditions. And I think if you find one, then hopefully they will be able to kind of make sure that there's not a different condition like sarcoid. And then if it is double seronegative NMOSD, how would it be best treated? So I think they can bring both diagnostic benefits and treatment benefits there. Yeah.
All right. Has stem cell treatment worked is an option for double seronegative patients?
Yeah, I'm not aware of many people who've had stem cell treatment in double seronegative
Mhm.
NMOSD. It does, work somewhat, it seems, in multiple sclerosis, in very, very severe, active, inflamed multiple sclerosis. Stem cell transplant seems to have some benefit, but I don't think it's been well studied in double seronegative NMOSD, but something maybe for the future.
All right. So let's go here. Oh, hello from Athens, France, Sweden, North Dakota, Calgary. That's cool. Da, 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 da. Let's see. I've had both, but more so in the spine. I'm new to this and have not yet been started on a preventative. My spinal tap only confirmed no MS. I'm anxious about what my treatment options are. So I think we established that with treatment options for double seronegative, you kind of just have to go through and see what
Yeah, it's a
works,
bit
right?
trial and error. We look at many different types of immunosuppressant treatments. Yeah.
Okay, let's see. Okay, let's go here. I hear ELISA tests for MOGAD generate a lot of false positive and false negative results. How can I ensure I get the right cell-based assay test? Should I retest if I can't confirm my initial MOGAD antibody test was cell-based?
Yeah, so I think it's difficult because a lot of times sometimes it doesn't say in the report on your medical record or things. So it can be hard for people to know. Most in the United States, most of the commercially available antibodies are cell-based assays. So I'm not aware that ELISA is even made available.
Okay, good.
But what I will say is that the live cell-based assay may have some benefits over the fixed. So if you're negative on the fixed cell-based assay, you might want to consider looking for a live cell-based assay. And that's done in a variety of different centers around the world. And indeed, in the latest MOGAD diagnostic criteria, there's a supplementary table. So if you go into the back and you'll find out all the antibodies that are available commercially and what different techniques they use. So that might be a way to look in your region. Is there an antibody test or which antibody test you had? So that's a kind of a resource as part of the diagnostic criteria, but it's kind of hard to find it to the back of that.
Besides testing for the autoantibodies themselves, are there other approaches to determine whether or not a patient's immune system is producing AQP4 or MOG? What about examining the B cells themselves?
Yeah, that's a great point, and I think we're trying to learn more about that, and that's why we do these samples and we get peripheral blood stem cells from patients when they give a blood sample, and we're looking to see what are those immune signatures. Are there cells that are targeting the aquaporin 4, their T cells targeting the aquaporin 4? What is the B cell repertoire? So I think down the line that may be a way that we could pick up more cases that maybe we don't pick up with the antibodies. So, but we're not quite there yet. So I think we're just doing more and learning more right now. But this is why it's so crucial that people get involved in research. And we really appreciate the efforts that people have made, including yourself and many others, to promote research and to get involved with research. Each different sample that a patient gives might be perfect for us figuring out what the disease is. And, we learn so much from our patients. The stories that our patients tell us every day really make the difference. We do lots of these studies about MOG antibody disease and MRI findings. It's something I'm interested in, but that's all based on, a patient comes into me, tells me their story. We look at their MRI together and we see these different findings, or they tell us some of their symptoms that they're having, and then we can figure out and kind of try and disseminate that for the broader community. So I think the patients are so crucial for all of this, given their samples for research, telling us their stories, and that's how we learn what things are working and what things are not working.
It's a team effort.
Yeah, absolutely. Yeah.
Is rituximab the usual first-line therapy for double negative NMOSD? What are the treatment options for those who fail on rituximab? I have to say, I relapsed on rituximab 3 times.
Okay.
So it did not work for me.
Yes, it doesn't work for everyone, but it is one that tends to work for many different conditions that are autoimmune.
Yeah.
So it's one we often try because say again, if we're worried it could be MS, we're not really sure, then it works across a broad range. But if that doesn't work, sometimes we'll target the interleukin 6 or IL-6, which is a medication called tocilizumab that we use. That's kind of an off-label, but we can try and get that approved by our insurance companies. Or other things, we use mycophenolate, also called Cellcept, or azathioprine is another medication we can sometimes.
Azathioprine's Imuran?
Imuran, correct. Okay. Yeah.
Got it.
Yeah.
Can my neurologist in Sweden send my AQP4 and MOG blood work and/or spinal tap to Mayo Clinic to retest me again for the antibodies or the other unknown antibodies? I sent the first question. Smiles from Sweden.
Yeah, yeah. So the samples can be sent internationally, so there are ways to do that. Now, sometimes there's regulations on where you're allowed to send a sample, or there can be additional costs with sending it further. There's also places in Europe, like at Oxford, they have the very good testing for MOG and aquaporin-4 antibodies. In Barcelona, in Germany, there's many places. So there are many different options, but it's sometimes good to go to one of those expert centers that's doing a lot of the research, because a lot of times they can sometimes develop a test that's really high quality, and sometimes they can also figure out if there's a different antibody. So that's the way we discovered the aquaporin-4 antibody at Mayo Clinic, was by patients giving their samples and us looking under the microscope and seeing a pattern. So for double seronegative NMOSD patients, there may be other patterns that we can see under the microscope, and then we can kind of figure out what they are. So I think there's two benefits there. One is that you may pick up cases that are aquaporin-4 antibody positive, but not picked up in the local test. And then you may also find a research antibody potentially. And that's the way we learn. Yeah.
Okay. Is it true that up to 40% of MOGAD patients lose the MOG antibody over time? If so, doesn't that mean that many double seronegative NMOSD patients may have had MOGAD, but were simply not tested when they actually were producing the MOGAD antibody?
Yes, exactly. That's a great point.
Earlier. Yeah.
Sometimes the MRI can be helpful there, because we talked about multiple sclerosis, meaning multiple scars in the brain. With the MOG antibody, for some reason, the lesions tend to disappear over time. So when we follow those patients' MRIs, if your doctor says that many of your lesions went away, that's not typical of MS, and that might suggest that it's MOGAD. So sometimes, even if the antibody is now negative, we can say, oh, that looked like MOGAD, because all of the lesions resolved. And with aquaporin-4, the lesions tend to persist. They get much smaller, but they tend to leave a bit of a scar. So with MOGAD is the one where all of the lesions tend to resolve. So sometimes that's a way of us telling, even if we don't have the antibody and they weren't tested at the time or it wasn't available, that was probably MOGAD. And particularly MOGAD affects children too. Yeah. So when we see children where that happens, we're highly suspicious for MOGAD. Yeah.
Okay. Let's see. What sort of research is going on regarding double seronegative NMOSD today? Are there any interesting early results or recent developments that you could share?
Yeah, I suppose there have been some other antibodies that cause a similar syndrome. There's one antibody to GFAP, glial fibrillary acidic protein, that we sometimes test for in the spinal fluid, that can look a bit like NMO or MOGAD. So that's one that you can test. There's another one called CRIMP5 we talked about. So we are discovering new antibodies all the time, and that's why it's helpful to send a sample, even a research sample, to an expert center to try and figure out, is there a different antibody that was not available when they were tested first. So I think that's one of the interesting areas that we're discovering. And then, from a treatment standpoint, I think we have those trials to go off. The treatments didn't really work that well, but maybe there might be a bit of a signal. So I think we're a bit behind on the treatment, and we need to ramp that up and try and figure out a treatment for seronegative NMOSD.
Which specialized hospital/center do you suggest in Europe for double seronegative NMOSD?
I think there's many centers. There's a Dr. Friedman Paul in Berlin. There is Oxford. Jackie Pallas at Oxford has expertise. Dr. Dalmau in Barcelona runs the laboratory. They have a lot of expertise over there. In Lyon, Romain Marinier has a lot. Sarah Mariotto in Italy. So there are many different people around the country. And I think if you look at kind of some of the studies that are happening, if you follow those studies, you'll find who the experts are. And I'm sure you have them listed on your website.
Definitely. Too. Okay. So here's another one. Are O-bands detected in seronegative patients during attacks? If so, how does that happen? They were present in my TM attack in 2018, and I ultimately had an NMOSD diagnosis based on that TM attack, optic neuritis, and brainstem involvement based on the different attacks' clinical presentation.
Yeah, so I think it's a bit variable. We know that oligoclonal bands, or O-bands, like it was mentioned there, are found in about 88% of patients with MS, and with aquaporin-4 positive NMOSD, it's about 20%, and with MOGAD, it's probably about 10% or so. With the double seronegative NMOSD, we don't know as much. It's probably, again, in that range of 20 to 30%. So most patients won't have them. And then some patients have them, but then they go away. So if you test them a second time, they're gone. With MS, they usually stay around and they're present in almost 90%. So if they are positive, you always want to think, could this be MS? And, you might want to see a specialist and say, are we really dealing with MS? Because we've lots of good treatments for MS now. So we would at least know how better to treat patients, even if they were thought to be seronegative NMOSD, if it turned out they had MS, kind of thing.
So I want to ask you a question. So NMO, obviously, we learned a lot about it from MS, so it became its own disease. We have the antibody, the 2015 criteria came out, huge developments. And that, I think in 2019, the American Academy of Neurology declared that year as the year of NMO. And then MOGAD started getting all the hype, and now that's the hot topic, and everybody's talking about MOGAD, which is fantastic. Do you think that double seronegative NMO is going to be that hot topic sometime?
Potentially, yeah. Or maybe, we'll find that there's 3 or 4 more different antibodies, and it will be one antibody at a time that we'll figure out. So I think there is a lot of interest. And, the fact that we've gotten so much interest from the pharmaceutical companies to develop these treatments, because it's always hard with a rare disease. But we've got so much interest that I think that they've shown an interest now in MOG antibody disease. And I think after that, they're going to show an interest in seronegative NMOSD. So I think having those pharmaceutical companies on board and interested is really helpful to kind of bring treatments for these patients and bring clinical trials so we can find a proven treatment.
Definitely. I oftentimes worry that we're going to be forgotten about because there's so much focus on AQP4 positive patients and MOGAD positive patients.
Yeah, no, but I think we have to remember that that everybody still has a single disease, and that double seronegative NMOSD is just as important as a MOGAD patient or an aquaporin-4 positive NMOSD patient.
I agree. Okay. Is there a different prognosis for double seronegative patients versus seropositive NMOSD patients? If so, what are the differences? How do they compare to MOGAD patients?
Yeah, it's quite variable because there's probably a mix of different syndromes in there. So I think it's a little bit hard to compare. And like you said earlier, some patients continue to relapse because we don't have the treatments for them. So I think historically, before we had good treatments for the aquaporin-4 positive NMOSD, it was a very severe disease and really debilitating. And now that we have the treatments, that's really changed the prognosis for that condition. So I think it depends on how we get treatments over time. So I think and then the other question was about unknown antibodies. Yes, I don't know. We know that the aquaporin-4 is on the astrocyte, and the MOG is on the oligodendrocyte. They're brain cells that we have. So maybe we should be looking at other proteins. The MAG protein on the oligodendrocyte. There's probably other proteins. So I think that's up to us as researchers to try and figure those things out. Yeah.
I am going to ask the audience, if you haven't already, or if you already did it, just do it again. Tell us in the chat where you're from. I would love to see where everyone's from, what country you're from, if you're the patient yourself, or if you're the caregiver. I think it would be really helpful for us to see, that there are double seronegative patients all over the world.
Yeah, that's true.
All over the world. Maine. Okay, cool. And so definitely go ahead and tell us in the chat where you're from, and we're going to answer the next question, but I can't wait to see where everyone's from. What are the typical comorbidities, other symptoms affecting double seronegative NMOSD patients? Which clinicians, AHPs, should they go to besides their neurologist to address them?
So I think firstly, the ophthalmologist, a lot of these patients have vision problems, so they should see a neuro-ophthalmologist who specializes in optic nerve issues. And then sometimes if their vision is severely affected, they can see a low vision clinic where they can give them a different adaptive devices that can help them with their vision. So I think that's a very important component. And sometimes they can do testing, something called an OCT, where they can take a picture of the back of the eyes and figure out how those things have been affected. Otherwise, from the standpoint of the spinal cord being affected, sometimes patients will get stiffness, or they'll get spasticity, where the legs get very stiff. And for that, they need to be taught how to do stretching exercises. So a physical medicine and rehabilitation physician, sometimes called a physiatrist, can be quite useful. And with them, we'll involve our physical therapists and occupational therapists to help kind of with those rehabilitation aspects. For the bladder, we'll often involve our urologists to help, because sometimes patients need to do catheterization themselves temporarily or in the longer term, and sometimes gastroenterology to help with bowel issues too. So there's many different specialties, and then sometimes people if they have a lot of neuropathic pain, may pursue alternative treatments like acupuncture or other things. And we're very supportive of all of those approaches. Yoga, mindfulness can sometimes help alleviate some of that pain without the side effects that comes with medication. So I think all of those approaches can be helpful for patients. Yeah.
Super. Have you had any double seronegative patients who did not cleanly fit NMOSD criteria or the criteria for any other diagnosis, but who you still suspected had some sort of autoimmune neurological condition? How were they treated and what was the outcome?
Yeah, I think we get a number of patients who are referred over to us who don't fulfill those NMOSD criteria. And sometimes when they don't, we find something else. So we found many patients who had sarcoidosis, and then we can get them on a specific treatment for sarcoid. We've also found patients who had genetic conditions where that's important also to recognize mitochondrial disorders or other things. So we do sometimes find patients who don't fulfill those criteria who end up having something else, or they end up having MS or vitamin B12 deficiency. So I've seen many of those different patients, and we actually have some studies looking at that. But then there are patients who who we know the immune system is overactive, and sometimes we discover a different antibody for some of those patients, like the CRIMP5 antibody, like the GFAP antibody. So I think it's very important that you look for those comprehensive antibody panels to see if we can find an antibody. For example, there's one to glycine receptor antibodies, which is an antibody that kind of quietens down your nervous system, and if you get damage to that, it kind of hyper overactivates your nervous system and makes your muscles stiff. So there's many different antibodies. So I think there are many different immune causes. And the other thing to think about is if you give a sample of blood or spinal fluid, we can look at the immune signature and we say, well, we know this is autoimmune. Which of those things should we target? Like if the interleukin 6 is up, let's target interleukin 6. If the TNF alpha is up, we can have a TNF alpha blocker. So we have different things that we can use based on the immune profile. So even if we don't know what the cause is, we still should be looking at the immune profile to see if we can find some target to go after for a treatment rather than just doing it blindly.
I told you I'm not a science person, but to help me remember some of these acronyms, what did you say,
TNF alpha.
So I call that TNF alpha. Okay. And then there is Janus kinase.
Jack kinase,
I call it Janus kinase. Just helps me remember.
Sure.
Okay. Are there any trials underway to test off-label use of the newer therapies approved for seropositive NMOSD on seronegative patients?
Not that I'm aware of right now, but I think it's something we should advocate for.
Definitely. I agree. Okay. After my first and only NMO attack in November 2021, which led to my diagnosis after finding a spinal lesion through an MRI scan, I was tested for MOGAD and AQP4, and both tests resulted negative. I asked my neurologist for the possibility to repeat those tests, but he told me that such tests have a high sensitivity rate to the antibodies, so there would be no reason for me to repeat the testing now. Should I ask another professional to repeat my antibody test?
Yeah, I think the physician is probably not too far wrong in that it's unlikely. It's less than 1% probably will go from starting at negative to going to positive, unless sometimes there's things that interfere with it, like plasma exchange is a treatment that removes all of your antibodies. So the day after you get plasma exchange, none of your antibodies will test positive no matter what you test for. So if there's some mitigating circumstances, then definitely the test should be repeated. Otherwise, I think it's worth talking to the doctor. Sometimes you might need to persuade them or ask them in that way about maybe retesting the antibodies. I think it's a fairly simple test. Or, you could ask, well, we only tested in blood. Should we go back and test in spinal fluid? Now, I know nobody wants to go back for a spinal tap, which is not the most enjoyable experience, but in saying that, it can be important if it figures out the diagnosis. Yeah.
Okay, so we have time for 2 more questions. Are there different levels that the AQP4 blood test during attack versus remission? What does a test stating AQP4 levels insufficient but clearly not 0 indicate?
Yeah, so with all of these tests, we have a cutoff, and then we've looked over time and we've looked at the antibody in patients over time and looked to see, could you predict? Like, it would be nice if we could test your blood maybe by a finger prick every once a week and figure out when you're going to attack. But it hasn't worked out that perfectly. I think it's quite difficult. The antibodies tend to fluctuate up and down. And even when patients are on treatment and they're having no attacks, the antibody can still be very high. But sometimes the antibody will drop down just below the cutoff, but it's not completely negative.
Mhm.
So that might be those situations where it's slightly detectable, but we have to have a cutoff for these tests. So sometimes it goes below detectable and then comes back up. So that's just one of the challenges with our testing. Yeah.
Oh man, I have a question, but I don't know if it's dumb. Does menstruation affect testing levels and antibodies?
I don't know that it affects antibody testing. It probably affects hormonal levels and other things in the body, but not so much for antibody testing.
Okay.
I think the things that might affect it are treatments. So the plasma exchange, rituximab maybe might reduce it, or some of the other antibody depleting treatments that target the B cells. Some of those may reduce the antibody levels over time. Or IVIG is an antibody, it's pooled antibodies in the population, and you put them into the system. So if you put all them into the system, it may be harder to pick up that signal because there's so many antibodies in the system. Or, you know, the IVIG can also result in a false positive because you get an antibody from someone else. And if somebody donated blood who had ACPORN4 positive, then you could potentially have an antibody detectable there. Yeah.
Okay, we've got the last question and then the final question. So 2 last questions. For double negative, the first line is Rituxan, but now they are doing the biosimilars. But are you seeing problems with biosimilars? I feel I don't do as well on the biosimilars.
Yeah, we've transitioned some patients. I haven't found too many problems. You know, the idea is that they're almost identical, but I understand that sometimes there can be changes in the way they're manufactured, or there might be slight differences. So it may depend on which one you get exactly, but they should work in theory. And there are ways of testing if they're working on your B cells. So you can test your CD19 and CD20 count to see if they're actually 0, because when you're on those treatments, they should be 0. So that's one way of checking if the biosimilar is doing what it's supposed to do. Now, different treatments may have different side effects or cause fatigue or other things. So there can be some aspects there too. But it'd be good to check and see, is the antibody doing what it's supposed to do, the biosimilar?
Okay. The final question, how can double seronegative patients help in clinical research? Is there anything that they can do to get more involved and contribute to future diagnostics, biomarkers, therapies for such patients?
Yes, absolutely. So I think there you want to sign up for research. So there's many of us doing research in patients with NMOSD. And I know your foundation is the Gutty Jackson Foundation. So there's many different avenues that you can search for. And I think we're all interested in enrolling such patients and learning more, because if we can learn about what might be causing it, then we can figure out a treatment. So there is ways, and that often just involves giving a single blood sample, or if you're having a spinal fluid analysis, allowing us analyze some of that spinal fluid too, or sometimes even doing MRIs of the brain or other additional sophisticated tests. We can learn more and more about the research. So again, I'd like to thank everybody who has given their blood for research. This is how we got treatments for the ACPORN4 positive NMOSD. It's going to be how we get treatments for the MOG antibody disease, and it's going to be how we treat seronegative NMOSD. So it's really crucial, and each person is a cog in that wheel of developing a treatment.
Yeah, we're part of something bigger than just our own illness. Okay, and then just from you, lastly, do you accept new patients? Do you accept patients from out of state?
Yes, we do. So you can call the Mayo Clinic, and we have a referral line, and then sometimes there can be rules around it, but we like to see NMOSD patients, so they will be a high priority for us to come to Mayo Clinic. Yeah, and you're welcome to reach out to me if there's any issues, or we try and help out patients as best as we can.
Wonderful. And then what are some words of encouragement you can give our double seronegative patients who are watching this?
Yeah, I think if you look at what's happened with the ACPORN4 positive NMOSD, we've gone from a really devastating disease now to a very treatable disease and manageable disease. Patients are doing very well. And I think more is coming down the line for the MOG antibody patients next, and the double seronegative patients. So I think we're going to find probably more antibodies that might define exactly what type of disease some of these patients have, and then develop a treatment for each one. So I think there's lots happening in the future. There's lots of research ongoing, and I think there's lots of hope for our patients for the future.
That's really, really good to hear. So that means as patients and caregivers, we need to make sure that we're staying up to date, we're informed, we're aware, but that we're also getting involved in the various ways that you said. So if you are so inclined, definitely try to get involved in some of these studies, donate your blood, because it will only help the greater cause in finding out what's going on with us.
Yes, exactly right. Yeah. So thanks so much for all that you do. And thanks for all that everybody on the webinar has done, because it's from many of those patients that we've learned so much, and that we're
working on finding more. So all of us want to just get the best for the patients.
Oh, thanks for joining us. This was a
Yeah.
pleasure.
Yeah, thanks.
Thank you, Dr. Eoin Flanagan. Again, this webinar is going to be available online for replay. And if you have any other questions, please feel free to email them to contact@sumairafoundation.org. We will try to get them to Dr. Flanagan, but we're so grateful for your time, your
Thanks so much.
expertise, your kindness. And guys, I think the future is bright. So stay strong, keep advocating for yourselves, and we're going to think positive, and I think the future is bright. Thank you, everyone.
Thanks, everyone.